Good morning. I want to thank you all for sticking around to hear this last talk. I believe this is the last talk of, no, one more, sorry, okay. Next to last talk. I certainly want to thank the Foundation for inviting me to speak today, and of course, Geraldine Bliss for inviting me to talk to you today about something that I think affects a number of patients and their parents in this room, which is epilepsy. So I have sort of an ambitious set of objectives that I'd like to go over today. Hopefully I'll have time to go over them all. We'll see. The first is to provide some really basic understanding of what are seizures and what is epilepsy, and show you what different forms that seizures can take. Because I think a lot of parents don't really know that there are a number of ways that seizures can actually present. They can be relatively subtle and can sometimes take a trained neurologist, for example, to really identify. I'll describe very briefly some of the life-threatening complications of epilepsy, and this is basically to provide some understanding of why it's so important, if you think your child might have seizures, to seek treatment. I'll also review the literature on epilepsy in general and autism very briefly, and then the literature of epilepsy in 22q13 deletion syndrome or Phelan-McDermid syndrome. And then I'll talk a little bit about our experience at Texas Children's Hospital in seeing patients with Phelan-McDermid syndrome and epilepsy. And then the very last thing, if we have time, is to talk a little bit about the role of cannabis or cannabinoid derivatives in the management of epilepsy, because I know this is something that frequently comes up in my clinic, and in the day and a half or so that I've been here, it's come up actually many times. So I know this is an important topic to many of you. So what is a seizure? A seizure is basically just a transient disruption of brain function due to abnormal or excessive electrical discharges in brain cells. And this can be seen either physically in the clinical manifestation of seizure, or through brainwave testing or electroencephalography, looking at how the normal background brainwave activity is disrupted by seizure. And then what is epilepsy? So what's the difference between seizure and epilepsy? Epilepsy simply means an individual has had more than one unprovoked seizure. With this being relatively key, unprovoked, meaning that the seizure was not due to something like a head trauma that resulted in seizure, but rather due to either inherent properties of the neurons or, for example, genetic abnormalities such as Phelan-McDermid syndrome. So what do we do if we think a child might have epilepsy? There are basically two diagnostic studies that all children that have had one unprovoked seizure should undergo. The first is an outpatient EEG or electroencephalogram. And again, this basically measures the brainwave activity in an individual. And you can see a child here on the top panel having scalp electrodes placed to measure brainwave activity. This is important even in the context of a child that's not having an active seizure, because we can often find abnormalities that suggest brain irritability and a predisposition to seizure. It's also important to have an outpatient MRI of the brain to look for structural abnormalities that might predispose to epilepsy, and potentially that might be amenable to surgical treatment. And then finally, if a child has epilepsy, we talk about medications as the first line of treatment for seizures. So what can seizures look like? Seizures can look like a lot of different things. And as I'll show you in a few minutes, it appears that in kids with Phelan-McDermid syndrome, at least in our group, that the most common type of seizure is a staring spell. And staring spells can be due to basically two different types of seizures. The first, which I think is the most common type of seizure in Phelan-McDermid syndrome, is an absent seizure. And I'll show you an example of this in a minute. So an absent seizure is a very brief staring spell, typically lasting only about 10 to 15 seconds, although it can last slightly longer, and then can occur with something called stereotypies, and these are complex motor movements that can be associated with seizure. I'll show you an example of this in a minute. A second type of staring spell is the complex partial seizure. This is typically a longer staring spell lasting a minute or perhaps a few minutes, often associated with eye deviation, meaning the eyes are sort of forced to one side or the other, and this can evolve into a more generalized seizure that you might typically think of as a seizure with generalized rhythmic movement of arms and legs. Atonic seizures can also occur in Phelan-McDermid syndrome. These are also called drop attacks, and these are sudden losses of tone. Usually they only last for a second. They're very, very brief, but despite the fact that they're very brief, can actually be quite devastating because of injuries that can be sustained during atonic seizure. Then atonic seizure is almost sort of the opposite, which is a generalized increase in tone without what we call clonic movements, which are rhythmic movements often associated with seizures. And tonic seizures can either be partial onset, meaning they tend to affect only one side of the body, or generalized in onset, affecting both sides. And then a generalized tonic-clonic seizure is what most of you probably typically think of as a seizure, which is this generalized violent rhythmic movement of extremities. And then finally, I'll show you an example of myoclonic seizures, which we do sometimes, although relatively rarely, see in Phelan-McDermid syndrome, which are sudden jerking movements as well, but these are very brief and not rhythmic in nature. So this is an example of an absent seizure, and what you'll see is this little girl initially has her eyes closed and is breathing heavily, and that's not part of the seizure. She's actually being asked to do this. And then suddenly you'll see that her arms fall, and she's just sort of staring straight ahead, and that's when the seizure begins. So here you can see she's breathing heavily, not part of the seizure. She's being asked to do this. And then suddenly her hands fall, and you can see some lip smacking, which are these stereotypies we talk about. And then her hands, you see she's sort of picking at her clothes, which is also part of the seizure. So she does this for a few seconds, and then you'll see she comes out of it and looks at her mom. So again, seizures can be very subtle without the sort of violent rhythmic activity that you might expect for a seizure. So this is an example of a complex partial seizure. In this case, it's not really a staring spell, but you'll see more complex movements of her lower extremities, sort of bicycling movements. And then as the seizure evolves, you'll see eye deviation to the left, as well as her head turning to the left, which is part of the seizure. So you can see the bicycling movements, and then her eyes are deviating to the left. I hope that wasn't for me already. Okay, I guess not. And then in a few seconds, she comes out of it. So in contrast to the absent seizure, where kids tend to come right back to their normal mental activity, sometimes with complex partial seizures, and especially with generalized seizures, generalized tonic-clonic seizures, there's a period of what we call a post-ictal state, where it takes some time to completely recover. So this is an example of an atonic seizure, and you'll see this little child just playing with a ball with one of the nurses. And you'll see a sudden loss of tone in just a second. And so right there, she had sudden loss of tone. So you can see the seizure is very brief, but when an individual has an atonic or drop seizure, this can result in significant, often facial injuries due to the loss of tone. And then the last example I'll show you is an example of myoclonic seizures. And these are generalized myoclonic seizures, but they can be partial onset, so this sudden jerking sort of movement. In this case, there's no change in consciousness, so this individual's mentation is normal. But you see these sudden jerking but non-rhythmic movements. So all of this was just to point out that seizures can look like a lot of different things. They are not always these very violent rhythmic movements. Seizures can appear in many different ways. Okay, so what are some life-threatening complications of epilepsy? And sort of the subtitle of that is, why do I need to worry about treating my child for epilepsy if they're infrequent or relatively short? And the first potential complication is something called status epilepticus. And this is defined as either a state of continuous or recurrent seizure activity during which cognitive recovery is incomplete. So it can either be one very prolonged seizure, or it can be multiple short seizures without recovery to normal baseline. By definition, we say that this is defined as a seizure lasting longer than 30 minutes, but by convention and in clinical practice, we treat any seizure or groups of seizures that have lasted longer for 5 minutes as status epilepticus. And so part of why we worry so much about status epilepticus is that in contrast to most seizures, where I say if your child has a brief seizure lasting a few seconds or even a few minutes, we don't worry about any sort of permanent brain damage, which is often something that I'm asked about, or about a risk of mortality. In contrast, a seizure lasting longer than 1 hour, we do worry about this. And as you can see in this graph, seizures lasting longer than 1 hour in duration are associated with significant mortality 30 days following the seizure. However, mortality in status epilepticus is very much dependent upon the age at which it occurs. And individuals that are older, that is in their 60s, 70s, and 80s, have a much higher risk of mortality following an episode of status epilepticus. And this is probably because of the etiology, where those individuals are more likely to have something like a massive stroke or neoplasm that caused their status, rather than younger children, which it's more likely to be something potentially genetic or developmental. So the second complication we worry about is something called sudden unexpected death in epilepsy, or SUDEP. So SUDEP is something that's really not well understood at this point. What we do know is that it can occur within minutes or hours following a seizure, and is often not even associated with a witnessed seizure. This is most common in adolescents and young adults, but as I'll show you in a minute, it's extremely rare. And it's most common in individuals with generalized seizures as well as genetic causes of seizures. The etiology of SUDEP is not completely clear, but there have been many hypotheses that have been put forward, such as autonomic dysfunction leading to apneic episodes or pauses in breathing, as well as cardiac arrhythmias. As I mentioned before, the incidence of SUDEP is really quite rare, but it appears to be most common in late adolescent, early adulthood, where you can see the incidence. The incidence of SUDEP is highest in late adolescent, early adulthood, but again is much less than 1 in 1,000 person years, so it's still quite rare. Okay, so what do we know about epilepsy and autism in general? Well, we can break down the prevalence of epilepsy and autism in those individuals with intellectual disability and those without. Those with intellectual disability, the prevalence is about 24%. Whereas those without is much lower at about 9%. However, this is much greater than what we see in neurotypically developing children, where the prevalence is only about 1 to 1.5%. We don't really understand exactly why the prevalence of epilepsy is higher in children with autism. We suspect it's due to a common etiologic cause, meaning that a single etiology causes both autism as well as epilepsy, but that's not clearly known. There's no particular seizure type associated with autism. All sorts of seizures have been seen: complex partial seizures, absence seizures, generalized tonic-clonic seizures. And again, it's an open question whether the co-occurrence or the increased risk of epilepsy in children with autism is due to a similar etiology, or could there be a cause and effect relationship? And the one that people talk about the most is whether seizures can cause autistic features. That's still a little bit unclear at this point. So in terms of EEG or brainwave abnormalities, all sorts of brainwave abnormalities have been described in individuals with autism, and the prevalence is really not clearly understood. This is a list of multiple studies looking at EEG abnormalities in children with autism, and this review found that the prevalence was suggested to be anywhere from 15 to 70% of individuals with autism have abnormalities on EEG. Again, there are no consistent abnormalities on EEG. All sorts of abnormalities have been identified, including diffuse slowing of the normal background activity, as well as focal and multifocal epileptiform discharges, suggesting propensity for epilepsy, as well as generalized bursts of epileptiform discharges, again, suggesting irritability and potential for seizure. There's no consistency in the frequency of epileptiform discharges, meaning that some EEGs from autistic kids will show a single abnormal spike in wave suggesting potential irritability, to some individuals having very, very frequent discharges of epileptiform activity. Some studies have suggested that using more advanced neurophysiologic techniques, that power and coherence in autistic individuals is abnormal, and this suggests abnormal connectivity between different regions, between different brain regions. And this is thought to potentially underlie some of the autistic behaviors in children with autism. So what about children with abnormal EEGs who do not have seizures? Do those children need to be treated? And this is relatively controversial in neurology and in epilepsy because there are no large placebo-controlled trials really looking at this. Some smaller trials looking at whether certain medications, in this case valproate and lamotrigine, which can potentially correct EEG abnormalities, could have positive effects and behaviors in children with autism. Some studies, some of these very small studies have suggested some improvement, but there's very conflicting data, and then other studies have not found improvement with these medications. So what do we know about seizures in Phelan-McDermid syndrome? Well, as of when I put this data together a few months ago, there had been 12 retrospective studies that in some way described seizures or epilepsy in individuals with Phelan-McDermid syndrome. The prevalence of seizures was anywhere from 14 to 70%, so quite a wide range. The one prospective study that has been conducted found a prevalence of about 41%. But in all of those studies, detailed descriptions of seizure types, frequency, medications used, or EEG abnormalities were not well described, except for in one that came out in 2014 that looked at 6 patients. So this is that study from 2014 from an Italian group looking at seizure types and EEG patterns in children with Phelan-McDermid syndrome. And what you can see is in this bottom panel that the patients that they had recruited had a wide range of deletion sizes, from very small deletions, primarily just involving SHANK3, to very large deletions involving hundreds of genes. Again, this study looked only at 6 patients, and 3 of those had a history of epilepsy. One of those, there were some confounders in the study, with one of those subjects having epilepsy but did not have a deletion in SHANK3. A second patient had a history of epilepsy but also had a history of a very severe infection very early in life called meningitis, which itself can predispose to epilepsy. This study suggested that all patients with deletions of 22q13 had a relatively benign course in their epilepsy with very easy to treat seizures. And the primary EEG abnormalities that they found were called multifocal spike and wave activity, which again relates to brain irritability and potential for seizure. Another study in 2014 asked the question of whether there was a change in the prevalence of epilepsy in Phelan-McDermid syndrome depending on age. And what they found was that there seemed to be a difference in prevalence of epilepsy depending on age, with younger children less than 5 years of age having a prevalence of about 10% prevalence of epilepsy, whereas those individuals that were adults older than 18 years of age had greater than 50% prevalence of epilepsy. So all of these studies have begun to address what is the prevalence, what are the seizure types in Phelan-McDermid syndrome, but I think there are still some unanswered questions. And that includes what is the spectrum of seizure types, the overall spectrum of seizure types in children with Phelan-McDermid syndrome? What are the EEG abnormalities in children with Phelan-McDermid syndrome, both with and without a history of epilepsy? And can EEG be used as a biomarker for clinical trials, which you've heard a little bit about from some other speakers earlier? And then, what are the most efficacious anti-seizure medicines for children with Phelan-McDermid syndrome? So I'll talk to you a little bit about our experience at Texas Children's Hospital. At the point I put this data together, we had seen 24 kids with Phelan-McDermid syndrome. We've now seen closer to 30. And what we find is that the prevalence of at least one lifetime seizure is about 46%. When I went back to those 12 retrospective studies and combined the prevalence from all of those studies, the prevalence of seizures in Phelan-McDermid syndrome is around 32%. So somewhere between a third to close to a half of children with Phelan-McDermid syndrome have a history of at least one seizure in their lifetime. In our group of patients, the mean age of onset was about 5 years of age, with a fairly broad range of onsets from 14 months to 14 years. And in terms of the number of seizures that patients have, it varied very broadly from one lifetime seizure to some patients having hundreds of seizures per day. In our group of patients, the most common seizure type was what we call atypical absence. That's these brief staring spells that I showed you earlier. But again, we found a very broad range of seizure types in our patients, including generalized tonic-clonic seizures, atonic seizures, myoclonic seizures, as well as focal onset seizures. Our group of patients that had a history of at least one seizure, 20% of them had a history of status epilepticus requiring intravenous medications to stop the seizure. And about the same percentage, 18%, had a history of Lennox-Gastaut syndrome, which is a very severe epileptic encephalopathy with very difficult to control seizures. So in terms of EEG abnormalities, we found that about 2/3 of our patients had a history of EEG abnormalities. And the most prominent type of EEG abnormality was slowing or absence of the occipital dominant rhythm. This is sort of the baseline activity of the brain. And we saw abnormalities in close to 50% of our kids with Phelan-McDermid syndrome. We also saw other abnormalities, including focal spike and slow wave discharges, generalized discharges, both suggesting irritability and the potential for seizure activity. I think really importantly, we also saw abnormal EEG patterns in individuals without a history of epilepsy. So individuals, even that have never had a seizure, can have an abnormal EEG. Then individuals with either more difficult to control seizures or multiple seizure types were more likely to have slowing of this baseline activity or occipital dominant rhythm. So I just wanted to show you an example here. I guess I'm close to running out of time.
Yes.
An example of EEG abnormality with generalized bursts of spike and wave activity. And I'll just mention very briefly that our patients have received all sorts of different medications for seizure activity, and we've not found one compound at this point that seems to be clearly superior. Other treatments such as vagus nerve stimulator or corpus callosotomy have also been used in some of our patients. I'll end and not talk about medical marijuana, unfortunately, but I can talk about it during the panel discussion because I know this is something that comes up for a lot of patients. So thank you.
Thanks.
Okay.
Julie, do we have a poll on epilepsy? Okay, let's start with the poll everywhere. Four of them. Okay, and let's let the discussions begin. Okay, we need our epilepsy panelists to come up to the front.
Powell from UT Southwestern Medical Center in Dallas, and I'm an adult neurologist, and sitting to my right are two pediatric neurologists. And yes. So we have Jerry and Peters from Boston Children's Hospital, affiliated with Harvard, and Jimmy Holder, who you just heard speak. I'm going to cut right to the chase and try and get to these questions so they all get answered. Any studies with marijuana or cannabis treatment as a treatment for seizures?
Unfortunately, I didn't get to talk about. I had a couple of slides about this. So there have been four. There's a lot of literature that are anecdotal and case reports and things like that. There are only 4 trials, I believe, that have been published. Actually, there's a 5th one, I think, that just came out, that have looked at derivatives of cannabis. So, and the primary one that everyone's excited about is CBD or cannabidiol, looking at this compound in epilepsy. And of those 4 trials, they were what we call open label. So these are not the gold standard sort of trials. 3 of those 4 did show some promise as a seizure medication. And I think the new one that just came out does as well. What I kind of wanted to emphasize with either medical marijuana or CBD are a couple of things. One is that most parents that I hear from are using preparations from individual pharmacies, things like that. And what we all worry about with those is there can be a tremendous amount of variability in those preparations in terms of the dose your child's receiving of CBD, in terms of other compounds, for example, THC, which is the psychoactive compound that gives people a high when they use marijuana. So, we definitely worry about those preparations not being very standardized and potentially having different doses of the various compounds. With all of that being said, I think CBD has a lot of promise as a potential therapeutic for epilepsy. We're still in the process of more trials, more data being collected to really show that it is useful in epilepsy, and more importantly, in which forms of epilepsy it's most important. I know there's a lot of talk in social media with parents who have children who had thousands of seizures and suddenly have no seizures with CBD. And I really think there's a lot of promise, but as with anything, you don't want to sort of get the cart before the horse and give your children supplements that are preparations for marijuana that you really don't understand what's in them, or there can be variability from one preparation to the other. And I'll just end by saying we have over 20 medications for the treatment of epilepsy that have gone through the FDA, that have been rigorously tested. A lot of parents will tell me, as soon as they hear their child is diagnosed with epilepsy, what about CBD? Let's start with the medications we know a lot more about before getting to that.
Thank you. I agree with everything Jimmy said. But I'd like to add a small note of skepticism. Keep in mind that just because it's a natural product, it's not necessarily harmless. It's a very active agent, and it has significant interactions with multiple medications. So when my patients talk about it, we try to review the data, at least superficially, about what's available, and it's about 50-50 until the most recent trial came out. There's small trials in TSC, tuberous sclerosis complex now as well, and it's going to go to a bigger trial soon. So it's exciting, but it's about as effective as any anti-epileptic drug. It's like a third or so that have some reasonable response. And we don't even know if that's through interactions of other medications, because many patients are already on 2 or 3. And for example, Onfi or clobazam gets pushed up way high when you add CBD oil. So what I typically do, and I have only 3 or 4 patients on CBD, and is I try to make a little bit of an N-is-1 trial per patient. And I don't know if that's very academic or not, but I do blood work. I admit them for overnight monitoring to get a kind of formal count and a formal quantification of seizures. And then we keep a diary, and then we introduce a drug, and we do the same thing. And then after 2 or 3 months, we evaluate, and we say, well, this is where we are. So that it's not like this open-ended question only by parental report, because there may be other improvements or changes they see in reporting as less seizures, like improved behavior or improved sleep or whatever. So just, talk to your doctor and make a good plan so you know if it's going to be effective or not.
I'm just going to summarize and say when it comes to seizures and when it comes to epilepsy, cannabidiol is a distraction right now, not a treatment. Can be a treatment, but it's a distraction from all the amazing treatments we have for seizures. Everybody who has a child with Phelan-McDermid with seizures ever, stand up. If your child has ever had seizures, stand up, Kim. Oh, never. Never. I'm sorry. I thought almost everyone in my table. Keep standing, please. If your child has had seizures, stand up. Yes. If your child has eventually gotten to a medicine where their seizures are essentially controlled, sit down. If your child's seizures are relatively controlled on a medicine, be seated. I know it's a confusing question, but so of those, and now everybody else can sit down. Of the people who has kids with Phelan-McDermid with seizures that are controlled on medicine, if that medicine was cannabidiol, stand up. Next question. Nobody stood up. Do they recommend 24-hour EEG for all PMS kids, just ones with abnormal MRIs, and what MRI findings could link to seizures? We'll start in the opposite way just to...
Okay, so EEG is a tricky test. We saw that almost a quarter of patients, even when they don't have clinical behaviors that are suspect for seizures, they can have abnormal EEGs. I don't recall if that included slowing or other abnormalities. I think it does. But in general, it's well known that epileptiform discharges, kind of the sparkling embers of an extinguished fire, the popping embers, can indicate an increased risk even when your child is not having active seizures, but it's not a perfect test. So if you start testing all patients kind of randomly, then you're going to end up with a lot of questions. What do you do with an abnormal EEG? Would you start treatment? So the answer is no, as far as I'm concerned, unless there's a clinical indication that there's a behavior that is sudden, recurrent, and stereotyped. And stereotyped means that it's exactly the same every single time. So to summarize, behaviors that could be suspect for seizures, as Jimmy was saying, seizures look like, I compare them to cookie cutters. So when you bake cookies and you use a cookie cutter, the cookies all come out slightly different, but they have the same legs and head, and sometimes the leg breaks off or the head comes out strange. But every single time you see this behavior, it's exactly the same, and that's what stereotype means. So if your child has sudden behaviors that interrupt normal behavior, that is happening over and over again, and it's like a cookie cutter stereotyped, then you are suspect for seizures, and then you may want to consider an EEG. If an EEG is abnormal, that doesn't confirm the diagnosis of epilepsy necessarily. The gold standard, the best possible evidence that you could get, is actually capturing a seizure while the EEG is running. And even then it's sometimes tricky. So when this question remains open, you try to do longer EEGs with video, even in the hospital if needed.
So I'll just add a couple of things. One is something that I meant to mention in my talk and forgot to, which is that staring spells, I mentioned a couple of different types of seizures it can be, but they can also be behavioral. So a staring spell is not necessarily a seizure. So how do you tell the difference? Well, one is the stereotyped sort of behavior, which is that it always looks the same. It's always the same length. The second is, what is the child doing before they have the staring spell? If they're actively doing something and suddenly stop their normal behavior and have a staring spell, that's much more suspicious than the kid that's sitting in front of the TV and you call their name once and they don't respond, and then you go over and touch them and they respond. That is much less likely to be a seizure. So it really depends on the context. And of course, capturing an event actually on EEG is really the gold standard for showing that for demonstrating that something is a seizure versus not. There's a second point I wanted to make and I forgot. So
Jimmy, Dr. Holder touched on a point that I think is a big. Couple of people asked this question: how do you tell the difference between just staring and a seizure, or an absence seizure and a staring spell? And he basically said the answer in his response. And basically, it's if your child is just looking away and then you touch them and they immediately respond, it's unlikely to be a seizure. However, if your child is doing something over time that you see that's always the same and stereotyped, talk to your neurologist about it. And if it's happening every day and they can get hooked up to and every hour, then an EEG will tell you if it happens during the EEG, whether that's a seizure or not, potentially. And if it's happening more frequently than once every couple of days, then a video EEG monitoring could capture those, and that would be definitive evidence. But talk to your neurologist about what you're seeing, about how often you're seeing. Videotape it. Videotaping it can be enormously helpful for your doctor. And we'll move to the next question. What can I do as a parent with a female child going through puberty to watch for seizures versus our non-typicals going through puberty?
So I think there's really not a difference between the young child and the older child going through puberty in terms of what to look for. It's the same thing. Look for stereotyped events that always look the same or the same duration with a change in mentation that suggests the potential for a seizure. And this is the same for both younger children and older children that are going through puberty. Certainly, puberty can change seizures in kids that have epilepsy. Seizures can come on after puberty or during puberty. Those are all possibilities because of changes that are happening, not just related to hormonal changes, but really just changes in the normal development of the brain that can result in seizures. And I've seen the opposite as well, where not necessarily specifically to Phelan-McDermid syndrome, but in general, where seizures are more frequent before puberty and then actually improve with puberty. So ultimately, you look for the same sorts of things, either in a child before puberty or during puberty.
I think we should move on. Neurologists aren't supportive of EEGs, is the assumption of this question. Is there literature that patients can present to their neurologist to show evidence that they need a baseline MRI or a baseline EEG? And I think the answer is simple. Unless getting a baseline EEG and showing that your child has an abnormality that's not related or relevant to seizures is not going to help your child, but it could be enormously helpful for research purposes. And in all the research RDCRN studies that are going on, EEG is becoming part of that or going to be added to that, and that can be enormously useful information. Clinically, I would say that unless there's a suspicion for seizures, there's really not a good medical reason to have some sort of baseline EEG. You guys agree or disagree, or is there a situation you could think of that's an exception to that?
I will say that for the kids that I see with Phelan-McDermid syndrome, I do get a baseline EEG. And the reason I do that is because it can be helpful if a child, I would not do that for every child, for certain. But the reason I do that is because it can be helpful in terms of, since there is a high prevalence of epilepsy in kids with Phelan-McDermid syndrome, if I see a change in behavior, I can then get a second EEG and look for a change, potentially a change in EEG that provides more evidence for epilepsy. And we were talking about this earlier, that even for a neurologist, and I think maybe even for an epileptologist, it can be somewhat challenging to definitively say when a patient first presents to you whether they're having seizures or not based on the description provided. And sometimes a simple outpatient EEG isn't enough to really determine whether a child is having seizures or not. So that's the reason I do it. I fully recognize that that's a bit controversial and that a lot of people would only do that test if there's a clear indication that this child is definitely having seizures. But to me, it provides some useful information. One thing I do want to stress, though, that I've seen actually, is that parents will bring their child to their pediatrician. The pediatrician will order an EEG and it'll come back abnormal and they have no idea what to do with that. I know, looking at the report, because this is what I do, what abnormalities, I'm really worried about, someone having hundreds of epileptiform discharges versus some other abnormalities that maybe are not as concerning to me. So if your child's getting an EEG, they should be seeing somebody, an epileptologist or a neurologist.
Very quick comment. If your concerns are not taken away by a brief EEG, the event is not captured, or you feel like you're being dismissed, then you need to push, because I do think you need to sort these things out, because untreated seizures is not good for development.
I just wanted to provide a little background information on, from the parent perspective. But I think often our children's seizures are very subtle, and it's hard for us to know. We're hearing and seeing from other kids in our community where they have maybe absent seizures that can be confused for staring episodes, or they have, in my son's case, little minor head bobs that became atonic drop seizures. So sometimes we as parents, we see some indicators, we're not 100% sure, and we may not have all the information. We need to advocate in order for our neurologist or for our pediatrician to refer us to a neurologist to get the EEG done.
Yeah, the session that you added after lunch for today on the consensus guidelines, if such papers would come out on Phelan-McDermid, we use these in tuberous sclerosis all the time to argue with insurance companies, for example, or to guide physicians who are less familiar with the condition to say, for example, very explicitly, there's, seizures are common, so are other recurrent behaviors, have a low threshold to do an EEG, or you can say, we recommend, based on this level of evidence, that for kids with recurrent suspicious behaviors, this amount of EEG should be done. And so those arguments, that literature is not available, but what Dr. Holder is about to publish, and hopefully the guidelines that we're going to come up with in the next year are going to provide documentation to support that.
Okay. Now we're in the lightning round because we have exactly 3 minutes. There were some questions about sedation and MRIs. It's a little bit off topic, but it's on topic because people often want to get an MRI with a child with seizures. And sedating your child is scary. And how can we communicate better about the risks of sedation and safety issues and ensure that everybody understands this? And I think that the take-home message that a lot of us have been talking about on the sidelines is, if you're going to if your child's going to have an MRI under sedation, it's safer and better to have it done in the presence of an anesthesiologist at a hospital or a major medical center, rather than an outpatient MRI setting with some, board-certified generalist doing the conscious sedation, especially for children with Phelan-McDermid syndrome. So I'll just make that point, and if you guys have something to add, go ahead.
Yeah, no, I'll just add, I think it should be done personally, I think it should be done at Children's Hospital with a pediatric anesthesiologist who's used to small airways
Exactly.
and protecting.
And sedation is not harmless, but it's not as harmful as full anesthesia used for surgery, because there's now more and more literature on suggesting anesthesia around surgery is actually harmful for the developing brain. But sedation is lighter. It's not as bad.
Are there specific meds that are known not to be effective for PMS? Yes or no?
No.
No. CBD, perhaps. No, they're not known not to be effective, but they're probably not effective. Can CBD prevent my child from having seizures? No. Are seizures worse for those with mutations, partial shank 3 deletions, etc.? Jimmy spoke to this. Just summarize that in one sentence.
That's a great question. We don't know for sure. In our group, we have just a small number of patients with mutations and same frequency of seizures, but it's a small number.
There were a couple specific questions. One child developed gallbladder issues. Could this be from seizure medicines, Keppra, Onfi, Lamictal? And I think it'd be good if that person who's interested in that would come up and talk to these guys afterwards, because it depends on what the medicines are, and we might actually have to look it up to figure that out. And let's see, are there any other things? Corpus callosum is extremely thin. Is there any research to suggest that this is related to epilepsy? Yes or no?
Probably not.
So it brings up another question, that if you have an abnormal EEG or seizures and Phelan-McDermid, should you then do an MRI? And I think that depends on what the EEG shows, because if the EEG shows generalized abnormalities, meaning they're all over the brain and don't point to a particular region, then you may not need an MRI. But I suspect most people would do it. Would order one.
So for Phelan-McDermid syndrome, I think the answer is we don't know. The reason that you might not need one is from our experience from other generalized epilepsies, such as juvenile myoclonic epilepsy, which is a different type of epilepsy, a very specific type of epilepsy, or childhood absence epilepsy, where we know those kids basically never have an abnormal MRI, and it's not useful. I think at this point we don't know for sure for Phelan-McDermid syndrome, so I do, but that might be something that we readdress.
Everyone, this was great discussion and great questions, and they didn't all get answered. So if anybody has more specific questions, these guys and myself were all available for the next hour or two at least, if not the rest of the time. Thanks. We'll move on.